Terrific. Well, welcome everybody. I think we had a record registered number of people tonight. So I'm anxious to see how many people participate tonight. We got a very lively discussion. I am Chad Tattini, the president of the Young Aesthetic Plastic Surgeons Committee, and we've been putting on monthly journal clubs in conjunction with NGE for almost 2 years now. So thank you and welcome. Tonight we have our featured article titled Improvement in Brazilian Butt Lift Safety with the Current Recommendations from ASERF, ASAPS, and ISAPS. We're honored enough to have the main author of the paper, Rios, tonight that's going to present it for the first 10 to 15 minutes. We're also honored to have our moderator, Doug Steinbrech, that will share his comments, and then we'll open it up to the crowd. I encourage all of you to chat throughout the discussion. Feel free to raise your hand, ask questions, and Doug or myself will try to get on board and answer the questions. I encourage you, if you're not asking questions, try to mute yourself so then we could hear everyone appropriately. So, Hunter, thank you for organizing everything. Thank you to the Aesthetic Society, ASJ, for organizing and helping with all of this. Just note that this is radar recorded, so if you want to come back to it at a later date, you can. So without further ado, I'm going to pass it over to Louis.
Well, thanks a lot, Chad, for having me here. And it's a real honor and pleasure to be here as the ASERF president. And so before I kind of get started on the paper, I just want to give a little bit of background on the paper and kind of so you kind of get an idea of what was going on in my head. I was a junior officer for ASERF, and when this paper came out, and I thought, wow, you know, that's pretty impressive. Steve Teitelbaum, our president, came out with something significant, like finally an ASERF president did something great here. And so, but even, you know, even though it was kind of not such great news, you know, it did point out a problem that we were having with the procedure, especially injecting the fat below the muscle. And so, you know, it was kind of alarming to see those mortality numbers. But what also came with the paper were some recommendations on how to maybe make the procedure safer. So, you know, as I sat as a junior officer in ASERF and kind of we went through another year or two, the first year after the paper, I asked, hey, can I do a follow-up? And said, no, it's too early. So finally in the second year, and then I was president-elect, I said, look, I think it's really important we put this message out and, you know, to maybe change our techniques, improve our techniques. And so just like liposuction, when there was, you know, kind of a question about mortality and morbidity, you know, with when we first started doing it in plastic surgery, I thought, well, let's go back and see with the recommendations that we had, if number one, did our members listen to the recommendations? Number two, did they change their techniques? And then ultimately, did we get an improvement in safety in the procedure? And so finally, after kind of sitting for 2 years, waiting to do the repeat study, I just felt as ASERF president-elect, and also since this paper came from ASERF, that it was our responsibility to follow back up and answer these important questions and not just leave this issue hanging out there. So that's kind of what was the genesis of, you know, how I looked at, you know, going back and looking at this again. And so we used the same types of questions, actually all the same questions, and then added new questions. So we can roll the slideshow, and I'll kind of go through it pretty quickly, because if you've read the article, you might already have seen this. So I've got no disclosures at all. I'm just the ASERF president, and we presented this at the meeting. So we can go to the next slide. Go ahead. I've got no disclosures. So here was ground zero. So I say ground zero because this is where it all started in 2017. It came out of ASERF. You know, again, maybe not such great news for those of us who did BBL, but it did point out the fact that, you know, maybe going under the muscle had some problems. And so let's go to the next slide. So, and basically again, and we all kind of know these numbers, you know, the mortality, the middle column there, range from 1 in 2,000 to 1 in 6,000, depending on whether you looked at quad ASF data or whether you looked at the survey data. And then when we looked at, you know, abdominoplasty, we all know that that probably has the highest mortality rate at 1 in 13. it was kind of shocking, that, oh no, now we've got another procedure that we've got some issues with. And so let's go to the next slide. So, but, with the bad news also came the recommendations, and these were, statistically significant. And so this is what came out of the paper was, okay, let's stay in the subcutaneous layer. Let's avoid the deep muscle. Let's avoid downward injection. And let's think about cannulas greater than 4 millimeters. So we did get some recommendations to possibly make the procedure safer. So next slide. However, with the aftermath of this paper, we got some positive things happening. We got more studies, and so a lot of our colleagues did some great groundbreaking studies. We sent out advisories from all our societies. We started ramping up education in all the meetings, and then all of a sudden we started, considering banning even in some of our societies started talking about it, and then there was actual banning in the UK. So let's go ahead and go to the next slide. So the impetus of the study, again, was to find out, were our members aware of the 2017 recommendations to improve the safety of the technique? Then did people change? And then what was the impact in mortality? Did we see a safer procedure with the change in techniques? So next slide. So what we did, the 2019 study is based off the survey, and we took the original 14 questions. We added 15 questions, to see if people had changed their technique. And then we got a decent response rate, 11.3% compared to 14.3% in 2017. Next slide, please. So then the question was, were we surveying the same surgeons, and next slide. We thought we probably were pretty close. It's a busy slide, but if you see there in the red, the only area that kind of flipped in response rate was really Mexico and South America. We had a little bit more representation from Mexico and Central America than the first paper. So, we're kind of confident that we were probably surveying the same surgeons. Okay, next slide, please. And then we also looked at, how many procedures did, our respondents do. And if you look at the two columns, it's pretty close. So again, maybe this points to the fact that, we were surveying some of the same people. And then 80% were doing the procedure in 2019 versus 88%. So we saw a drop off of some people not doing the procedure. And I think the biggest reason was they felt there was a problem with the safety of the procedure. Next slide. So this was the first question I wanted to ask. Were people aware of the 2017 recommendations, especially those 4 points, and trying to improve the safety? And 94.5% of those people that responded were aware of the 2017 recommendations. So that was a good thing. That meant that we were getting the message out as societies. Next slide. So then the next question, did people change? And so what we saw in 2017 is that 40% of the people were just in the subcutaneous plane only, and that switched to 85.5%. And then for those who weren't in the subcutaneous plane, 85% of them changed. So you saw there was this big change. And we also saw changes in the cannula size, and also in making sure that you weren't pointing your cannula downward. Next. Next slide. And so so this is where it gets a little tricky, because this is a survey study, and there's limitations to survey, and I'll talk about that in my last slide. But so people will ask, what significant findings did you get from this study? And I was lucky to work with Dr. Varun Gupta. I hope he's here. And if you have questions about statistical significance, you can ask him. He did a lot of this analyzing of the data. But what we had to look at with the amount, with the respondents and looking at the numbers, we could find a statistical significance in safety when we looked at recent pulmonary embolisms. And that's where we saw an improvement that was statistically significant. What we saw in the safety, where you see that first number, where now the recent fatal embolisms was at 1 in almost 15,000. That's a trend because this is survey data. So there's limitations to survey data, but it was a trend. And I think that when we see like this paper that came out of South America from Conde, I think we're seeing that the mortality rates are kind of closer to this than maybe to 1 in 3,000. Next slide. So the conclusions again, and I think, it was nice to see that, people were aware of the recommendations from 2017, and there was a good trend in change of techniques to the safer techniques. And then we did see improvement in some of the morbidity numbers, and definitely a trend in the mortality rate, which kind of, although this paper is not a direct comparison with abdominoplasty, if we look at the number, we're kind of approaching more the mortality of the abdominoplasty. And so I think, again, using the recommendations, and if we go to the next slide, we have reached acceptable safety, and these diagrams this artwork is in the paper. And so basically, the recommendations again are maybe use a larger cannula, 4 millimeters. So the thinner cannulas tend to bend, and you want to stay in the subcutaneous space and avoid the vessels. Next slide, please. And so again, we had limitations to the study, which are all here. It's a survey study. So next slide. And so as ASERF president, we've designed a strategic plan where we want to be a little bit more active, an active research foundation. So we kind of want to stop depending on surveys, and start getting into real data and getting the denominators. So I'm a big champion of our AND data project, which we have about 300 plastics society members on, where we can gather data. And we're actually developing a future society app where we might be able to gather data. And so if there's any of you out there that do a lot of this procedure and you're not on the AND project, if you could contact me so that I can get you on the AND project, because it would really be nice to start getting denominators so that we can, because we can send out surveys to see, over the past year if people had any deaths, but we really need to know the denominator. And so only by collecting real data are we going to be able to get away from these types of papers that rely on surveys. And I don't know if I have another slide after that, but that may be it. Yeah, so Doug, if you have any comments or anything, like I said, it's a pleasure to be here and kind of present the data and the background story. I think you're on mute, Doug, you're still on mute.
Okay, is that better?
Yes, yes, you're unmuted.
Okay, first of all, I would like to say thank you for Hunter and Phaedra and Dr. Nahai and everybody at ASJ for allowing me to be involved. The second thing, I'd like to thank my brother from another mother. People don't realize, but Dr. Rios and I are actually half siblings. Yes, we are related. No, we're just really good friends. We're on the leadership, which for any of the residents, if you're out there, I'm going to digress a little bit from tonight's agenda. But if you are looking to get involved with the society, this is my little push for the Aesthetic Society. It's amazing. It's wonderful. I'm so happy to be involved because I think it's so important to serve our society and our people and our doctors, but also I've made so many deep, great, wonderful relationships, and Dr. Rios is one of them. And if you do want to get involved very early. You don't have to we always think that you have to wait, and you have to be an old dog. You have to turn 65 before you start doing anything. You start very early, get involved as a resident, go to the residents forums, and then get involved with a committee. Even before you're a member, you can get involved with the committee and join, and then get involved with the leadership weekends. It's 2 weekends a year, and it's great. So Dr. Rios, I spent a lot of time at the leadership committee, and we really have bonded, and we've been great friends. I'd like to congratulate him on a beautiful and very carefully controlled study, and a very important one. This does go back, and this is really a survey that the Aesthetic Society and several members of the Aesthetic Society have been the leaders of and have done a lot of research on. And I just want to give those people credit. So we'll start with number one, Dan. come on, my buddy, Dan Del Vecchio. Like, this man is so, I'm not supposed to swear, incredibly, I'm not going to say that word, really very, very committed to safety, and he's committed to the artistry, and he's committed to what he does and what he loves. So Dan Del Vecchio was very important in a lot of the research that went into this, with anatomy dissections as well as clinical work. Also, Chris Chia and Alfredo Hoyos, and of course Tino Mendieta down in Miami, Dr. Gavami, another great friend out in Beverly Hills, of course Spiro Theodoros, from my colleague from across the street in New York, Alex Islani from Marbella, from Spain, and several other people from Mexico, Arturo from Mexico, and others from South America, and elsewhere, Europe. So these people have been so instrumental. They've taken away time from their practice. They've taken time from their families to go to South America, to go to Miami, to spend a lot of time to really study this for our benefit and for the safety of our patients. And we're indebted to them, and we should never really forget that. There's going to be a plaque that's going to go somewhere for all those guys that have participated. But it's also important not just to make recommendations, but to do follow-ups. And the other person I'm going to say is Steve Teitelbaum, because Steve, he's not afraid to get in there. Steve is not afraid to make his opinion known, even if it's controversial, and even if it's unpopular. He is the kind of guy that will stick to his guns, and if he feels something, he'll do the work to try and figure it out. Sometimes when we have early data, we learn more as time goes on, and this may have been one of those cases. But we should give thanks to Steve for putting it out there. And that leads us to another thing. One of the successful things about this is, and this is important for the residents, and sometimes when you do M&M, I did M&M in general surgery at NYU. Like, nobody likes to stand up there behind, in front of the general surgery department at UT Southwest or at NYU and admit your mistakes. Nobody likes to do that. And it's very tough and very difficult. But this is a case where we as a society and we as a group of surgeons, for our safety and for the ability to continue what we really felt was a great procedure, we had to admit that there were problems. And we had to go to the lab, and we had to do the research. And that's why I credit those guys, Dan and the rest of the gang, for not sweeping it underneath the rug, for admitting that there was a problem, not trying to hide it, and to beat the rest of the other people that would say it's bad, either the media or other research, and frankly, research done from people that weren't doing any of this, or decisions being made by administrative and groups and societies where people making the decisions didn't even do this procedure. And these guys were so passionate about what they wanted to do that they went and did the research to do this. So that's number one for the residents, is don't hide. Don't sweep it under the rug. You better figure out what's going on if you want to save the procedure, and if you want to make it safe, and if you want to save your patients' lives and decrease morbidity. Number two, you have to be critical. We all have to be critical with ourselves, with the techniques we do, and not just assume that if we just keep on doing them, they're going to go away. We have to figure it out. And we have to do the research, which brings me to blue applesauce. Blue applesauce is what we all did, and I still do it in the lab. When I go as visiting professors, I just did it down at UT Southwest. We went down there, we got in the lab, and we did all kinds of things. We put our implants in every possible cavity, but we also did a lot of lipocell transfer. I don't like to use the word fat grafting because it freaks out the patients, and it sounds like someone's going to put a big blob in your butt or a big blob of fat on your shoulders. So I'm trying to get us as a society and as clinicians, when we're explaining to our patients that it's not, you know, fat grafting. It's all about the words that you use. And if we use words like liposome transfer, I always tell them that we're going to take out that bad fat. We're going to take it out from the bad areas, from your love handles. We're going to take it from your gut, from your from the side of your chest. But then we're going to isolate those beautiful cells for structure and volume, and we're going to reintroduce those into desired areas. We're taking those cells from undesired areas and putting them into desired areas so that for the rest of your life, if you have a carb, because we know that fat doesn't make fat, carbs make fat. If you have a carb, if you have a bagel in the morning or a donut, or you have a little dessert afterwards, the dirty little secret is it's going to fill those cells. And why not have it fill the desired cells in the desired areas? And also prevent what I call catch fat, compensatory adipotrophic cellular hypertrophy, or fat in other undesired areas from increasing in size, which is the dirty little secret that we all know that happens, but we sometimes don't admit it to ourselves, or we don't admit it to our patients. And that's why our next ASERF grant is to solve that problem. But getting back to what we're talking about tonight is really about the safety and about blue applesauce. Because when we were down at UT Southwest, or what we tried to do at Rush, but couldn't do because of COVID, is to inject that fat and have the residents see where it goes in the cadaver. And in the cadaver, we can demonstrate it safely, and we can demonstrate it unsafely. So that's exactly what we did. And we saw through these videos, and this is a killer video that Dan and the other guys did. Ladies and gentlemen, when I say guys, I mean ladies and gentlemen, because our plastic surgery community is made up of men and women. But what these people did is they injected this blue applesauce because it's most like the consistency that we can find. There are other things that people use. This is most like the consistency that we can find. And you make it blue to make it a color that shows up that is different than the applesauce. It looks like fat. But when you inject it in the fat, we see in the upper layers, we see that it doesn't penetrate through the muscle, because going through that fascia is very tough. And in fact, I mean, breaking through that fat, through that fascia can be difficult. But if you're new to this, or you're not really quite sure, or you don't do a lot of these, you can pop through the fascia, just like you can go through the rectus abdominal wall and you can put air underneath the diaphragm. You can do that with a cannula, particularly a small cannula. So we can't get cocky, and we have to stay safe. But in the cadaver lab, we can use blue applesauce. And whenever I get to university, I make ask the secretary to go to the grocery store and get some applesauce and some blue dye. And we find that if we inject it in the skin, underneath the skin, it stays there. It doesn't go to the fat. The other thing, which is the clincher, is Dan and the other doctors showed that if you go through, penetrate into even the superficial muscle, but really into the deep muscle, what happens is it goes not only through the muscle down to the submuscular area, but it also follows along the planes. And very little of it, candidly and frankly, stays actually in the muscle. Some of it does, and we know, and I know it does, because I put in submuscular and intramuscular implants. So when I go in with a patient who wasn't happy, he didn't get enough fat, and we actually put an implant intramuscularly, I do see tapioca fat all the way through. So I know some does go in the muscle, but not as much as you would think does. A lot of it just climbs through the planes between the medius, the maximus, and the deep muscle, and it just goes through all the way to the submuscular area, and it does two things. Number one, it increases the pressure of the area, and that causes pressure on the veins and creates a rent purely by pressure. You don't even need physically to pierce it with a cannula, just based on pressure from it. But if you do that, there's going to be a big sucking sound, a black hole of the pressure, the higher level pressure of the applesauce or the fat that you've just injected 300, 600, 900 cc's of fat that you thought was going in the muscle slipped right through the muscle, went deep, and it's pushing on the venous system from those gluteal veins. Not only that, but if you happen to make a rent in it, then it goes right in, it flushes right through the venous system, because obviously the venous system has a smaller pressure. It's going to suck in all that fat, all the applesauce, and you have a dead patient right on the table. And it can't even happen even if you don't make a rent, even if you don't physically pierce the veins. So Dan's video shows that when we open up the cadaver after we've injected all this, and you open to the deep area, deep to the muscle, all of this blue applesauce comes running out with really high pressure. So not only, number one, did you not put it in the muscle, so you didn't do number one thing that you were supposed to do, but secondly, you put your patient at risk to die on the table, to die later, or just to have morbidity problems. But the third thing you did is all that fat that you thought was going in the muscle actually didn't. It slipped through the planes and went deep. And what do you think is going to happen? You think that any of that fat's going to survive, is going to add volume to your patient? Absolutely not. It's just going to create necrosis, fatty necrosis. It's going to create a problem. Also, it's going to create a deep infection, because none of that's going to get any blood supply, which we need with micro injections, right? That we've all seen. That it's not going to survive. There isn't nearly the muscular or the vascular supply that's down deep. There's none. It's only the big vessels. So not only are you put your patient at risk for a PE or a venous thrombosis, but you also, none of that fat survives, and you're going to put your patient at risk for a deep infection, because you're just going to have dead fat that sits down there. So that's also very important. The other thing I'd like to say is a little bit about what I do, because I do body banking, which is the same thing, lipocell transfer. I use it in other areas. I put it in the shoulder, biceps, and other areas, which you also have to be careful with. For all the areas, incidentally, that I do, I stay in the subcutaneous space. Why? Because I actually believe this stuff. I believe, particularly when you're starting out, to start very superficially. Keep with larger cannulas if you can. Obviously, I put in the abs. I can't use a greater than 4 millimeter cannula when I put in the subcutaneous space in the abdominal area for abdominal highlights, or in the shoulders. But when you're doing gluteal, make sure that they're big. Make sure that the angle is up. You don't want it to accidentally go down. You can use a mechanical or an electrical probe to show you that you've pierced the muscle if you really need that. Usually you can be able to tell. You also want to use your other hand. Your other hand can help guide you, but don't trust that only or implicitly, because even using your other hand, you can be fooled, particularly for the younger people. You know, I'm an old dog, right? But even old dogs can make mistakes. Old dogs can be distracted by what you're talking about or the music on the radio. We're all human. Until we have robots that do this, we all can make mistakes. So don't trust yourself. But these are ways I'm not a very smart surgeon. I always like to keep it simple. Keep it simple, stupid, and that's going to keep me out of trouble. That's going to keep my patient out of trouble. So know the anatomy, keep the angle up, know the danger zones, know the mechanisms. Like, some people were still, even when we had our Aesthetic Society gluteal augmentation panel that was a great success, I think, because of the people that tuned in, but also because of our great panel. I was proud to be helping out with that we had in April. But we found that people are still putting it into the muscle. They're either putting it out laterally, but even people like Tino. I love Tino. Tino is another brother from another mother. Tino Mendieta is brilliant. I learned everything I did from him. Even he's not injecting into the muscle so much anymore, even laterally, and even not into the superficial muscle, because nobody can be completely sure. But particularly for the newer people that are trying this out, stay safe, stay sub-Q. And we even find that we get better results, because the lipocell transfer stays very well, survives very well in the subcutaneous space. So I think that that's all I have to add from my non-scientific perspective. But we have the chat open for questions, or if people want to just open up, come off mute and ask questions to the amazing Dr. Rios, then let's go ahead and start to take a few questions.
Doug, we do have a question.
Good.
Let's throw this to Dr. Rios. For both abdominoplasty and BBL, is there any risk stratification data to help us in patient selection? Did you hear that, Dr. Rios?
Yeah, so again,
What is going on up there?
Is this something going on?
No, some
Whoa.
people, everybody needs to mute. Some people who are viewers who join us are not muting, and they have either a beautiful young child or a dog that's barking in the back. So unless you're talking, go ahead and mute. Thank you. Go ahead, Dr. Rios.
Yeah, so I think, you do your usual risk stratification, with the comorbidities and all that. And I think the big things here are, BMIs greater than 30 are going to increase your risk. Obviously, once you start hitting 35 to 40, you're going to really increase your risk. So, you may really want to be careful with those types of patients. And then I've just found, be very careful with the hemoglobin levels right ahead of time, because if you're going to do a lot of liposuction, let's say on the back, and get up to that 5 liters, and then you're going to turn them around and do an abdominoplasty, you could have some problems in the post-operative period. So I think you just got to have you don't have to be super conservative, but you really just need to keep an eye on just normal risk stratification and keep an eye on the hemoglobin ahead of time and how much you aspirate at the time.
There's another question, Dr. Rios. What garments and restrictions do you have post-operatively?
So a lot of times, because I'm doing the lipo, I'll put them in an abdominal binder right off the bat. Unfortunately with this, and I don't know, Doug, maybe you can comment on this too, but with the aggressive liposuction that we have to do to make that tiny waist and get all the fat out that we need to put in the buttocks, there's a lot of drainage, and I tried to do this without drains. And so I find myself with drains. And so putting on a garment right off the bat isn't very comfortable. So I start with an abdominal binder, and then I use one of those BBL pillows where people sit on their thighs and not on their buttocks, and just kind of have them off the buttocks for 2 weeks. And some people will even go for 6 weeks using that pillow. Once we get the drains out, then I'll go to a certain type of garment that leaves a little less pressure on the buttock region, but a little bit more pressure over the liposuction regions. Doug, are you having to use drains when you aggressively do this lipo? Because I tried everything not to, but if we're creating those small waists, I just feel, there's just so much drainage that you just have to deal with seromas, and I just don't like seromas.
Yeah, I do use drains. I use drains for the men and for the women. Less for the abdominal portion for women. I use Penroses for all the men, for all the women at the upper gluteal crease. I try to avoid using a infragluteal incision if possible, only because I see women or men who, if they want to be in a thong or want to be in a bikini, that they really don't want to have those incisions. So I try to avoid them. But what you really have to do is you have to, let's just talk about incisions for a second. You have to speak with your patients, and you have to give them the choice. I find that I can do all my suction, and if I really need to get down low, I can use it from a lateral hip or a lateral band incision right at the waist or the lower waist. So a woman or a man could have a low swimsuit, but it would be covered. But if they want to have the thong, then they don't have that subgluteal incision. I know a lot of people completely feel the other way, and they say that their patients don't want any incisions on their hips, maybe in the upper gluteal crease, but not in their hips. and their patients would rather have an infragluteal small puncture incision. So I think you have to ask your patient, because I know some feel very strongly either one or the other, but ask your patient if they had to have an incision, or God forbid, a hypertrophic scar or a keloid. We always ask this incision, or this question: where would you least want it to be seen? And then that's the way you have to address it. And I always say to all my patients, all the residents, whenever I speak, I've never try and make as few incisions as possible. I've never had a patient complain about the incision that I did not make, which sounds stupid and sounds very basic. But if you've never made that incision, you're never going to have a patient complain about that. And you can have a patient have a 360 circumferential incision, but if you put two small drains, which is why I never do this, down in their groin, they'll complain about the two drains, despite the fact they have a scar all around their belly. They'll say, when are these two vampire incisions going to disappear? So I talk to them about them. Right now, we're working on some cannulas to try and avoid some super cool new cannulas to try and avoid to have to make either of those incisions. But that's something that may be on the horizon, so that'll help. But yeah, that's what I would say about in terms of the post-op. I do use the Penroses. They come out in 5 to 10 days. They've dramatically decreased our rate of formation. The 1-inch foam, the 3M 1-inch foam has been a game changer. It's completely changed my life. There's only one very important caveat, and if you remember anything from tonight, remember this, is you can't just put it on directly, because you can have either post-inflammatory hypertrophic staining or some bruising in the areas where you don't have the foam, or you could have some blistering from the edges of the foam. So what you want to do is you just want to unfold, and these are top secrets. So I'm going to reveal them. You want to unfold one gauze, either soft gauze or a textured gauze, and you just lay that gauze. It fits it perfectly, but don't use the foam naked against the skin. You're going to have blisters around the edges, particularly on the sticky end that's adherent to skin. So on that sticky part, you have to put down a piece of gauze. I have them keep it on for 3 to 5 days, and then for the abs, I just take it off. But for the flanks, and particularly on the men, because we take it out of the sides, because men want to have a spaghetti squash, very high, superior and inferior, and they want to have that lateral, very sexy concavity with a beautiful convexity posteriorly. Some women even want that as well. Most women either want a tight little bubble butt, or they want more of a Kardashian-esque appearance. In terms of compression, I don't cut anything out from the back. You don't have to, or you can if you want. If you feel better, you can go ahead and do it. And by the way, no one has shown any definitive superior way in terms of compression or foam or anything like that. I feel that the foam and the compression works great for me. Some people like to cut out the back. Some people like to have a garment that has a thinner, like a scrim in the back, that's a thinner material around the glutes. Some people, I know some doctors that use no compression whatsoever. They do the glutes. They just tell them not to be on their stomach. Some people tell them that they can go home and be sitting on their tush. So no one's found anything superior. So you kind of have to do what's most comfortable for you and most comfortable for your patient.
Great comments. One of the numbers that struck me in the paper was 85% are still using syringes. Louis and Doug, could you comment a little bit on your injection techniques?
So I use and I've got no interest in it, but I use a Wells Johnson HVAC, which is basically a foot pedal, 4 millimeter thick, straight cannula, single hole. I'm pointing up the whole time, and it's a stiff cannula, so it's not going to bend down into the vessels. And it's got a blunt tip and just a single tip, and I press on a button, and the fats going out, and I can really control what's going on. And since I'm not using a syringe, I'm not having to use one hand to try to push the syringe. I've got two hands, so I can put one hand over the area that I'm putting the fat in, and I can feel the tip of the cannula. So I'm able to use two hands with the syringe. Sometimes, you're having to put a lot of pressure, and sometimes you even find yourself using two hands to push the fat in, which is, dangerous if you're now below the muscle and you're putting a lot of pressure and you puncture a vessel, or you're putting just a lot of pressure. So I prefer to use a mechanical infuser. It also has pressure. It has pressure reading, so it tells you when the pressure is getting a little too high. But thick cannulas pointing upwards, the machine to help me, so I'm not putting too much pressure and it frees up my hands. That's what I do. What do you like to do, Doug?
I think I do a variety of areas, and they're not as big as the gluteal area. So I use a variety of cannulas, and there are going to be some instances, if I'm doing a serrated stripe or the obliques on the side, there's no way to use a 4-millimeter cannula. It just doesn't make sense. And I'm just right underneath the skin. So the chances of having any really specific danger in those is remote. So if I'm doing it around in the delts anterior, lateral, posterior, for me, you could maybe do it, but 4-millimeter is a little bit big, so I can use a 2 or a 3 for that. And for the upper chest, I can either use a 4-millimeter because it's a bigger muscle area, just like the glutes. I think when you're starting out, I do have the Wells-Johnson, and we can reverse the pump and go back and do EVL. That's another thing. I mean, Dan Del Vecchio and Simeon Wall and all the other guys that were instrumental, but really Dan and Simeon, I think, are the key players who deserve the credit, and also Alfredo down in Bogota. Using the EVL is a great tool with the Wells-Johnson. I have no interest in Wells-Johnson. they told me to get it, so I got it. But you can use any column and then let it separate, take out the juices, and run in the slurry. But those when you're starting out, using EVL is a great, safe way to do it. And then when you get more advanced and you feel more comfortable and you're using smaller areas, you're not going to do a 4-millimeter fat grafting cannula into the upper, the zygoid or the into the zygoma. We're just not. So there's going to be some areas of the body that we're not going to do it. For the purposes of this discussion and for the glutes, I think it's a very safe, and it's a very good approach that all the the people, all the real innovators have developed and have done a very good job. And it's a good place for people to start, or even old dogs like me that have never done this before. It's not too late for y'all to go ahead and do it. And the other thing I'm going to say is, in these days where where this COVID thing is happening and people are looking for other things, maybe there are some people that have only done facelifts or they're only doing noses. And they do want to try and do sort of venture into this area. You can do it, and this is a great paper to show you how to do it safely in this time where people are looking for other techniques to be doing.
That's great information from both of you, and thank you. We are wrapping things up. We've got, I'm going to ask you one last question here. What are your guys' threshold to start chemoprophylaxis on these procedures? Do you do it at everybody? Do you stratify them? Can you elaborate a little bit on that?
Wow, thanks for that question. But look, some of the studies that have been done, definite chemoprophylaxis for Caprinis greater than 7s, right? But we're usually not running into that in our practices, right? So I think when you look at our literature, when it's 7 and above, you definitely need to be doing prophylaxis, right? So when you're coming down to 40-year-old female, maybe a little bit overweight, you're probably starting to hit about 4. In general surgery, they start considering chemoprophylaxis at 4. In our literature, I don't think it's completely proven yet. And, you know, Chris Panucci does a lot of work here, and I've done a safety course with him, so I'm kind of repeating what he says. So I think he's not in favor, you know, of doing this for someone that's got a, you know, a Caprini score of 4 or 5. But I tend to go ahead and do it, and I'll do it on my tummy tucks, and I'll do it on these cases as well. The downside to it is you could get a hematoma, and I've had that maybe on 1 or 2 people. But upside is maybe you're prophylaxing against this, DVT and PE. Now, you got to remember that people can still get DVTs and PEs even a month later. So if you're giving prophylaxis for 7 days, you may not, you know, hit that one, you know, a month later. But, you know, I do it for all tummy tucks. I keep an eye on them. Yes, I've had 1 hematoma. But I'll tell you what, I had one experience where I did do chemoprophylaxis and someone got a DVT. They didn't get a PE, but I was able to look at them in the face and say, look, I did everything I could to prevent this. And, you know, I was able to kind of walk away from that conversation feeling better. But I think we don't have the literature that says that you know, at Caprini of 4 or 5, we don't have that literature that says you need to do it. So it's almost like on an individual, you know, thing. You got to do the Caprini score. You got to have that. You got to do the assessment. And then after that, you know, you need to decide what philosophy you're going to have. The only thing really in our literature is if you're getting up to 7, Caprini score of 7, you should really be prophylaxing at that time.
Yeah, I completely concur with all of Dr. Rios' comments. I will say that I'm the same way. I follow you do have to do the assessment. You do have to do the scoring. And then even if you don't have the time, you're a little bit sloppy, your staff's not going to keep track of those things. It's common sense. It's comorbidity, patients that are older, patients that have risk factors, right? And we know those. Patients that, you know, that aren't going to be active post-operatively. Bigger cases, longer cases, and combining cases. Like anybody, if you don't know that list and if you don't follow that list, you're not going to pass your boards, right? Like, and we all know that, so you're all going to pass your boards. So just for those things, a lot of it is common sense. We try not to do defensive medicine. I had my appendix out last week because I had appendicitis through all this COVID stuff. But I got, just for a 12-minute procedure, endoscopic lap appy, I got it. And I'll tell you why I got it, because I'm a doctor, because I'm a plastic surgeon and fantastic, best bariatric doctor in town down at NYU took out my appendix. But she's like, I'm not this guy. Louis Rios knows my 4 F's for complications. 4 F's, right? What are they, Louis? Family?
Right.
Friends? Famous. And that doesn't mean you're in Hollywood, or it just means the local senator or something like that, no matter where you live, the mayor. The last F is physician, right? F stands for physician. So, you know, if you're dealing with a physician or something like that, or somebody's famous, like, they're going to get a complication. So for a 12-minute procedure, I got chemoprophylaxis. And guess what? See this bruise right here popped up? And also I have a nice hematoma, periumbilical hematoma, which is going to take a while to settle out. Otherwise, my procedure went great. So probably didn't need it, you know, but I got it. So not everybody needs it, and we don't want to do protective medicine. And by the way, you didn't hear from me, but there may be data coming down the pipe that says that maybe chemoprophylaxis doesn't do everything or as much or as effectively as we originally had thought. But for now, for the purposes of what we're talking about tonight, and to be safe, particularly for the younger people, really take the time. I know when I started my practice, there were just crickets. There was plenty of time. There was no one in there. I just heard crickets. So I did have time to study up and follow the Caprini score and set it up in my office. Good.
Well, perfect, guys. Thank you so much, Dr. Rios, Dr. Steinbrech. Thank you for the visual aids, Dr. Steinbrech. We appreciate that as well.
Yeah.
It was a fabulous, fabulous discussion tonight. I think we had record numbers. And again, it's great to see these studies and these papers improving patient care. And we've definitely seen the improvements, and I'm anxious to see what the coming years, and listening to you again, Dr. Rios, in a few years with the new numbers. So we will adjourn tonight. Thank you all for showing up. Please tune in the first Tuesday of every month, and we'll have another fantastic discussion for you all next month.
Thanks
Thank
so
you,
much,
Dr.
guys.
Rios. Thank you, Dr. Steinbrech.
All right.
Thank you, guys.
Have a good night.
Bye.
Have a good night.